reiterate, this set of notes is not on your third test. It's going to be on your fourth test, right? So everybody will have had time to like do it in lab and have some time to absorb this kind of stuff. So it'll be on your fourth test. Your third test is the brain notes, yeah, and then the autonomic nervous system notes and heart. Good? Which seems like it's actually a lot once I looked at it because the brain is kind of complicated. Good? Okay. But this definitely corresponds directly to the heart stuff. So I think where we left off was we were about to talk about capillaries in more detail. Is that right? Yeah? Do you guys remember that arterioles are the vessels that are right before a capillary bed? Everybody remember that? Arterioles are right before a capillary bed. And because arterioles are right before a capillary bed, they're really active in vasoconstriction and vasodilation to control differential blood flow to capillary beds. Because, for instance, you don't need the same amount of your 5 liters of blood going to all organs at all times. Right after you eat, for instance, you will need to dilate the arterioles leading to your digestive capillary beds. You with me? So you send more blood to that area right after you eat, yes? But when you're working out, you don't need to send a disproportionate amount of blood to your digestive tract, so you would shut those down, and you would dilate the capillaries going to your skeletal muscles, yes? Okay. This is why your mom told you not to go swimming after you ate, because mom is always a little bit right about these kinds of things, and she did keep you alive, right? Right? Or one of your parents did. Somebody kept you alive, because babies are always trying to kill themselves. So this is why she said not to go swimming right after you eat, because what you got is 5-ish liters of blood, more for dudes, less for girls. And what happens is right after you eat, you try to send a disproportionate amount of that blood to your guts, yes? But then if you start working out, you're going to be trying also to send a disproportionate amount to your skeletal muscles, right? And your skeletal muscles might not get enough to contract as they need to. And that's not a problem if you're running or jogging, because you just sit down, right? But it is a problem if you're swimming, right? Because you sink. So that's the problem, right? It's like trying to send a disproportionate amount of blood to 2 different places. Now, how often does that occur? Well, we're all still alive, so apparently it doesn't occur that often, but she wasn't wrong. And how many of you guys have gone swimming right after you ate? You know, I live dangerously. I'm going to jump in, Mom. But we all live through it, okay? So that's an arteriole, and now we're going to talk about capillaries. Capillaries are really simple in their structure because all they have is a layer of endothelium, simple squamous epithelium, and a basement membrane, no smooth muscle, no connective tissue, right? And what they need to be is really, really thin and have a lot of surface area for gas exchange. And that's how they are actually formed, lots of surface area for gas exchange. They're tiny, tiny thin. This is scanning electron microscopy, a different type of microscopy that shows you that this capillary, which you see in the long section here, right? This capillary is barely bigger than the red blood cells that are trying to get through it, right? So the thinnest capillaries are so thin that red blood cells have to go through single file. That makes sense? Okay. So they're really, really thin. These are red blood cells. That's a platelet. White blood cells are bigger than both of them. Okay. So there are basically 3 categories of capillaries depending on how impermeable versus porous you want to be. And so these are the 3 categories of capillaries. Notice that as you move from the left to the right, you get wider. Do you see that one's wider? Yeah. And you also get more holes. Yes? Okay, so this is the most protective capillary. It's really, really controlling about what gets in and out of it. All of the cells are stuck together with tight junctions, okay? And so in order for something to get out of the capillary into the tissue around, generally speaking, it can't go between the cells, it has to go through the cells. And if you force something to go through the cells, do you have more or less control over what you transport? Way more control over what you transport. Does that make sense to you guys? Okay, so tell me a location in the body in which you would probably find these capillaries, which are called continuous capillaries. Yeah, the blood-brain barrier, exactly. The blood-brain barrier is made of the tightest capillaries. So they're these continuous capillaries, but they're even better. They're continuous complete capillaries, meaning that Almost nothing gets through without permission, not even water. Water can't even get in and out of these without going through the cells. It can't go between the cells. So you even control the water transport in and out of the cells. So that's a continuous capillary. Moving up to the next one, this one has fewer tight junctions. It's still got quite a few. But in addition, the cells have what we call fenestrations, and fenestra means window. So here's the deal. If you look at one of the simple squamous epithelial cells forming the capillary from the side, what this would have is places where you have holes, kind of, but think of them as double paned glass. What happens is in this location, you push everything but a little teeny bit of cytoplasm, and you push all of the organelles out. So all this is 2 layers of plasma membrane, right, which increases transport because there's very little impediment to transport. So this isn't a whole hole, right? It's basically a window with just a little bit of cell membrane in it. But it increases transport compared to, for instance, this, right? Okay, so these are called fenestrations or a fenestrated capillary. You find these in locations in which you need a lot of transport, but you still need some level of control over the transport. For instance, in the capillaries that are just behind your intestinal epithelium, you need to do a hell of a lot of absorption. But do you want to absorb everything willy-nilly? No, you want some level of control, right? You also find these fenestrated capillaries in your kidney. Kidney does a lot of transport, but it doesn't want to lose whole blood cells, for instance, right? So we need to have some level of control of what gets through, okay? All right, so that's a fenestrated capillary. And then this one is called a sinusoid capillary, and they are wider. They are also curvier than normal capillaries. What does wider and curvier do to the speed of blood flow? It's going to slow it down, yes? So you're going to make it wider. That'll slow it down. Same volume of fluid in a bigger tube, right? Curve it. So it's going to go through more slowly. So these are slow. They are also not picky at all about what comes in and out of them. So let me tell you 2 locations where you find these. You find them in more than 2 locations, but 2 classic locations. One of them is in the liver, okay? We haven't done hepatic portal circulation yet, but I want to tell you that what your liver does is, of course, cleanses your blood. It especially is important in cleansing the blood that was absorbed from your digestive tract. So here's what happens. You eat, yes? You absorb nutrients, but your food isn't sterile, so you also potentially absorb toxins and pathogens, yes? So you might have eaten some spinach with some E. coli on it, right? Okay, so you absorb potential toxins and pathogens. With all that blood that you, those nutrients, toxins, and pathogens that you absorb, they go into your bloodstream. But what you do before you send them back into the inferior vena cava is you shuttle them through the sinusoid capillaries of the liver. And here's what the liver does. As the blood goes through these sinusoid capillaries very slowly, sitting on top of this capillary, you have a big old macrophage that's looking at the blood as it goes by. And what does it do if it sees something funky in there? It gobbles it up. Exactly, right? So you have to be able to take in whole cells, right? So you got these big old holes on the side, right? Okay, so that's part of what the liver does. And then I'll tell you one other place that you have these. I want you to see if you can figure out why these would be good in that location. The other place that you have these is in the red bone marrow. So what do you think you need big old holes in the capillary for in the red bone marrow? Any idea? Exactly, right? It's not always about taking stuff out. Sometimes it's about putting whole cells in. Red blood cells, white blood cells, platelets. I just made them. Here, have them. Got big old holes to put them in through. Yeah? Does that make sense? Okay, so that is a sinusoid capillary. Okay, all right, so now we are just going to talk about veins. Okay, veins are often called afferent vessels, right? And what veins are doing is carrying blood which direction, guys? Toward the heart, exactly. And so we have 3 different categories of veins. You've got the little bitty ones that are just on the other opposite side of a capillary bed. These are barely visible with the naked eye. We don't name them by individual names, right? These are called venules, just tiny little veins, okay? And they're just on the other side of a capillary bed. This guy right here is when you gather up several venules and get it into a larger vessel, not huge like the inferior vena cava, but like the size of like the brachial vein, right? Those are your medium-sized veins, and the medium-sized veins are most of the named veins in the body, most of them. That's probably what it is, okay? And then we are going to gather it up into the largest veins, and the largest veins include, for instance, the inferior vena cava and the superior vena cava. Those are big veins, right? Huge ones that you can see right there, okay? So, and then the large veins, are, of course, in systemic circulation are all going to dump into what chamber? Right atrium, right. So they're going to jump into the right atrium. Now this is all systemic. Pulmonary has a similar pattern, fewer vessels, right? Flipped oxygen content, but still a pulmonary vein would be going back toward, right, back toward the heart. Okay, so the structure of a vein and the variability of the vein. So let's see if this makes sense to you. Arteries have compared to veins, have very little variability in their number and their branch points and in their locations. And to me, evolutionarily, I think of this as arteries are on their way to work. So if, for instance, the two of us had individual variation in arteries, and we were both going to a capillary bed because we're on our way to work, right? But she had 2 branch points on the way to get there, and I took 16 turns on the way to get there. Can you see that there would be selective pressure against 16 turns on your way to work? Yes? Can you see that? Okay. So what we see with arteries is there's less variation in arteries from person to person. Yes? Okay. And there's less variation in diameter of arteries, so there's less arterial variation. But with veins, you are on your way home, and you're not in a particular hurry. Yes? You're farting around on your way home. You can take an alternate route if you choose. There's not tremendous selective pressure against it. In addition, you can be superficial or deep. That's no problem because you're a vein, right? You're on your way back. So there's far more variation in veins than there is in arteries. There's variation in branch points. There's variation in number. There's variation in lumen diameter. There's all kinds of variation because I am generally just farting around on my way back. And by the way, your veins contain a disproportionate amount of your blood at any given point if you are at rest. Like right now, just 45% of your blood is just farting around in your veins on its way back. It's not like going backwards or anything, but it's not in a particular hurry. But if you start working out, what happens is you just squish it and you squish it back into circulation. Does that make sense? Okay. So they act as kind of a blood reservoir on the way back. Oh, I forgot to tell you guys something cool. So before we get into veins in detail, I'm going to tell you one more thing. Go back to capillaries for just a second. Sorry. Okay, so I want to tell you one more thing about capillaries, which is kind of related to what I just talked about. So this is the arterial end of the capillary bed, and this is the venous end of the capillary bed. You with me? Okay. Capillaries don't really have any smooth muscle in their wall, except for a couple of places. This is an arterial. They skinned it so that you could see the smooth muscle, so it doesn't usually look like that. You just took out the outer portion. But this is a capillary bed. So I want you to imagine that this capillary bed is going through the wall of a uterus. Yes? Okay. You're delivering blood through the wall of a uterus. And what happens is this top picture is when you're just chilling, you got plenty of nutrients and oxygen that you can spend on your uterus, right? But the second picture is when a tiger walks into the room. Do you want the blood to just fart around on its way through the wall of your uterus if a tiger's in the room? Hell no. What do you want to do? I'm going to send it back into circulation. So what you have is these little cuffs. These little cuffs are called precapillary sphincters, and what those can do is shut down blood flow and force it through a thoroughfare channel to force it back into circulation really quickly. Does that make sense? So you don't have smooth muscle very many places in capillaries, but you do have them a few places in capillaries. And that's kind of the same concept of that we just talked about with veins. You can send it back into circulation quickly if you need it to. Okay, so back to veins, because I forgot to talk about that. Okay, go ahead.
Are you talking about like one person?
Yes. Yes.
But with our arteries, our circulatory system is very similar.
It's very similar. There are variations in arteries for certain. For instance, there's a cadaver over here that has some weird branch points off of her aorta and all that kind of stuff. So variations exist in arteries. Variations are the rule in veins. Like the picture that you see in your textbook, don't expect veins to look like that. right? They will only look vaguely like that. Like that might only be true in 30% of the population with veins. In arteries, the picture you see might be true in 70% of the population. So it's just pretty variable in branch points and that kind of stuff.
So
Go ahead.
the capillary bed, is that where it's in the middle part? Like, is that what you would define the capillary
Yes, that's a
bed?
capillary bed.
In the middle of the capillary itself?
No, the capillary bed is just a general term that means everything that's not an arterial and not a venule, all of that, all of the branching capillaries in between is collectively
So where,
called.
Like, all the capillaries are branching.
Yes, exactly.
All of that
Uh-huh.
capillary bed.
That's the capillary bed. Got it? Okay, so now veins. Back to veins for just a second. There's more variability. There are more veins, okay? And so veins are going to have to deal with lower pressure. See if you guys can come up with, last class could come up with 4 of them. Let's see if you guys can come up with some reasons that veins are lower pressure than arteries. Why are veins lower pressure than arteries? And they're going to have to deal with pressure challenges, and arteries don't. Go ahead. Yeah, the blood dribbles through it. It's on the back side of a capillary bed. Good. Okay. Yeah, well, yeah, it does flow uphill. So you got to go against gravity and bipedal organisms quite often. What else? Do you remember anything about diameter? Yeah, bigger diameter. That's going to drop the pressure. How about number? Yeah, if you've got 3 times as many with the same amount of fluid, then that's going to drop the pressure because you send it through 3 times as many tubes simultaneously. And then does anybody remember anything about the volume of fluid as you go through a capillary bed? What happens? Yeah, you lose fluid, right? So do you see that we've got all of these pressure considerations with veins? So in addition, let's just acknowledge that you're also way further away from the pump, right? So you got all of these pressure considerations with veins that you didn't have with arteries. So what we end up with is we're trying to get blood many places, not every place, like not in your head, but many places we're trying to get it to go against gravity, right? It's lower pressure, it's more vessels, it's larger volume, all that kind of stuff. So what we are going to have to deal with is you have to promote the unidirectional flow of blood through a vein in a way that you don't have to worry about in an artery because they're high pressure. And the primary ways that you do that is skeletal muscle. So the veins, not all of them, but many of them have valves in them. And the valve job is just what a valve job usually is in the cardiovascular system. It's to prevent backflow, right? That's what valves are supposed to do. And so this valve, let's say this is a vessel in your leg, yeah? And it's going back to your heart, yes? This valve's job is if I get blood up here, it can't go backwards. So what ends up happening, like in the vessels in your leg, is it goes choo, 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 kind of like going up a roller coaster, right? Choo, 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 choo. And so these valves prevent backflow, but then there's 2 ways that you can help get blood flow. If you squish on this with a skeletal muscle, like if it's one of the deep veins in your legs and you're walking around, right? You squish on it with skeletal muscle. When you squish on it, the blood can't go backwards. So which direction is it going to go? Up. So the more active you are with your skeletal muscles, the better what we call venous return you get. Better blood return to the heart. Yes? Does that make sense? Now, this is, of course, better with deeper veins and harder with superficial veins because there's not as many skeletal muscles around them, right? That makes sense? Okay. And then, so this is called the skeletal muscle pump. Yes? Just means that as your skeletal muscles contract, they tend to shunt blood back up. And then we have one other one, and this one's kind of interesting. This is called the respiratory pump. And the respiratory pump shunts blood back up every time you inhale, and this is why. Ready? Okay, I don't know if you guys have done respiratory system yet, so if I over-explain, it's not because I doubt your intelligence, just because I don't know if you've done this yet. Okay, so your diaphragm shaped like this, like bell-shaped when it's relaxed, right? And when you inhale, what your diaphragm does is push down, yes? And I want you to think about your inferior vena cava for just a second. Your inferior vena cava runs all the way through your ventral body cavity, right? From the abdominopelvic all the way up to the thoracic cavity, okay? So what I'm going to do is I'm going to breathe in, and it's going to squish down. The pressure is going to increase down here. What's the pressure going to do up here? Decrease, yes? So every time I breathe in, what happens is I end up squirting blood up my inferior vena cava. Because what do fluids want to do? They want to flow from high pressure to low pressure. Exactly, right? It is so effective that I don't even have any valves in my blood vessels in my ventral body cavity? Because I don't need them. Because how often do you breathe? Pretty damn often if you're still here, yes? Okay, every time I breathe in, I squirt it up what we call the respiratory pump, yeah? The respiratory pump is actually squirting blood up with every single inhale. Okay, so, all right, so let's talk about what happens if these valves are weak or if there is something compromising their flow. Okay, so if the valves are weak, like if you have a genetic predisposition to weak musculature or connective tissue in the walls of your vessels, does that make sense? Okay, what happens is the blood will pool on top of the valve and it can make it kind of balloon out, right? And that can be called varicose veins, yeah? Varicosities. They are more likely to form superficial than deep. Can you kind of see why? Yeah? Okay. And they are also associated with some professions and some practices. So any idea what kind of behaviors are associated with forming varicose veins? Standing. Yes. Not walking. Walking's awesome because your skeletal muscles keep going. But standing puts gravity, right, against these and then doesn't actually allow for like a lot of muscular contraction. So standing a lot, especially if you also have hypertension, high blood pressure, which is causing problem with venous return, even more if you are obese. And why? Because all of that you're pushing against, the blood has to go against it, has to go back against it. So what happens in these situations is if you have a genetic predisposition plus some complicating factors, you're more likely to get varicose veins. You see these a little more frequently in women than in men. Not that they only happen in women, but we tend to shave our legs, so you're going to see them. If you just get hairy, nobody would even notice, right? And men don't particularly care about them very often unless they start to hurt, right? When they start to hurt, it becomes problematic. But my husband just gets up in the morning and brushes his teeth and puts on deodorant, looks in the mirror and says, I am amazing, and leaves, right? The women were like, I spent an hour, I still look like shit, but I guess I have to go anyway. No, go ahead.
They tell a lot of pregnant women not to cross their legs.
Yes.
Is that also because
Yes. You've got all this pressure that you're pushing against. In addition, pregnancy requires higher blood pressure because you actually have more vessels, right? Okay. If you compound that with this, you're very likely to get varicosities during pregnancy. And also, I'll talk about the next kind of varicosity in just a second. So varicose veins has a genetic predisposition, and then some professions are very, very likely to get varicose veins. And what are those professions? Nursing. Yes. If you are going to be a nurse, and I hope you are, and I want you all to be fabulously successful at it, be a wiggly nurse. Do not be the nurse who sits around or stands around all the time. Be the one who says, hey, somebody needs to go get that thing. Go get that thing, right? Otherwise, you are going to be the fat nurse, which is also a complication of nursing. Lots and lots of obesity associated with nursing. And varicosities are a predisposition in nursing. Just because of the behaviors that you get into. So wiggle as much as you possibly can. So now, when varicosities occur in the wall of the anal canal, they are called hemorrhoids. So you have veins that are trying to return from everywhere, even down south, right? And hemorrhoids, of course, are more likely to form under certain circumstances. Anybody know what those are? Which one? Sitting too long. Truck drivers, hemorrhoids, right? Just sitting for long periods of time. What else? What? Constipation adds to it. Add obesity in, and you've got something that you're pushing against. Moms, please be honest with them for a second. All the little whippersnappers who haven't had children yet, tell them what else increases the likelihood of hemorrhoids. Pregnancy. Yes, it sure does. Increases the likelihood of hemorrhoids because you got a whole bunch of pressure that you are pushing against and trying to get blood back up here, right? And you are very likely to form hemorrhoids during pregnancy, which then you will probably have for the rest of your life. Yes. So just remember that and take some birth control. Have a baby when you're 30, not 20. Go ahead.
What about spider veins?
Spider veins are just really superficial veins that actually bust because of low pressure. They're usually so small that they don't have valves in them. Right? So they're still more likely to occur when you are dealing with pressure differentials, and they're more likely. This guy actually, or woman, has both. This person has both spider veins that you can see. Can you see the spider veins up here? Yeah? Spider veins are pressure, but they don't have as much musculature and smooth muscle in their wall, and they don't have valves. They're smaller veins, so they just tend to bust. A lot of times with spider veins, you don't need to do any intervention. With these varicosities that get this big, sometimes they'll have to go in and strip them out because they compromise blood flow. But with spider veins, there's so many of the little ones, you don't have to worry about it.
So then how come they don't just I mean, if they're broken, how come the body still sends blood to them, and why do we?
Oh, these are not broken.
The spider veins.
Oh, well, they're not broken everywhere, and so it's not like it's bruising. It's just like you've damaged these vessels to the point that they actually come to the surface. And eventually, sometimes the body will kill off a few of these, but a lot of times they just go and inject them with saline because they have very little blood flow going through them, but they still have some blood flow going through them, right? So they're not completely dead tissue. They're just like unnecessary tissue. So a lot of times they'll just like inject a high saline solution, close them down. But it doesn't work with these guys that are huge like that. And these are apparently really painful once they get that big. Yeah? Also, as you age, you're more likely to see them because your skin gets thinner. Yeah? With these varicosities. All right, so that's varicose veins. Okay, now, a vein that is really, really wide is called a sinus. You have very few arterial sinuses. Anybody want to hazard a guess as to why that is? You have a lot of venous sinuses, but very few arterial sinuses. Exactly. So venous sinuses are not uncommon, and I know you know some. So give me a couple veins that are called sinuses. Coronary sinus, yes. Superior sagittal sinus, inferior sinus, all those sinuses in the brain are sinuses, right? So if you run into a big vessel that's called a sinus, it's more likely to be a vein than it is an artery, okay? All right, so now what we are going to do is we're going to start doing circulatory routes. We're going to do pulmonary first because pulmonary is much shorter story than systemic circulation. And with pulmonary circulation, guys, remind me, with the pulmonary circuit, you go from what chamber to what chamber? Right ventricle back to left atrium. Good. And what are you doing during pulmonary circulation? Are you picking up oxygen or dropping it off? You're picking it up, yeah? You're picking it up from the lungs, yes? Okay. Now, a couple of little questions for you before we get into the specifics. Pulmonary circulation can be lower pressure than systemic circulation. And systemic circulation in an artery tends to be about 125/80. And you may have not learned that before, or you may. 125/80, 125 is 125, or 120/80, 120 millimeters of mercury immediately after ventricular contraction in your arteries. Does that make sense? Okay. And 80 is immediately before the next ventricular contraction. So that's systolic over diastolic, 120/80. So it's showing you the variability in like the brachial artery, for instance, okay? Now, pulmonary circulation usually is around 25/10. Do you see how much less pressure? So we know why that kind of pressure is adequate. Now, my question to you is what anatomical difference causes the difference in pressure between pulmonary circulation and systemic circulation? Yes, exactly, right? And remind me, which ventricle is much, much thicker and therefore generates more pressure? Left, got it. Exactly, okay? So the pressure in the pulmonary circulation is 25/10. It also has fewer vessels. So not surprisingly, with lower pressure, you are less likely to damage your plumbing, yes? Okay, so pulmonary circulation is nowhere near as likely to go bad as systemic circulation. And of course, there's also less tubes, right? Fewer tubes, right? So we don't see as many pulmonary cardiovascular problems as we see systemic cardiovascular problems. It's way higher pressure, right? And also there's more vessels, right? In addition, it also supplies your brain and your heart. So if those go bad, you're definitely going to know. Okay, so lower pressure than systemic circulation. Okay, so what is the path into pulmonary circulation? You guys know this. You leave out the right ventricle, and you go through which valve first? Pulmonary semilunar valve, exactly. And you go into the pulmonary trunk, yes. and then you split into the right pulmonary artery and the left pulmonary artery, which go to each lung, right? Now you can't see this on this figure, but I'm going to go ahead and tell you because it corresponds with things that you've learned before or are going to learn next week if you haven't already learned them. You, in a typical anatomical human, the right lung has 3 lobes and the left lung has 2. So does it surprise you that you typically have 3 what we call right lobar arteries branching off of your right pulmonary artery? Does that make sense? And 2 left lobar arteries, yes, branching off of your left pulmonary. So try to do right by what's left. Same thing in the lungs as it was in the heart. Got it? Now, some people always ask why 3 and 2. There probably isn't a why. It was probably just that we inherited it from some evolutionary ancestor because it is this way in all mammals. And it certainly could be another way. It doesn't make any difference. And this one has more surface area for gas exchange, but not because of the 3 lobes, but just because the heart is actually taking up some of the space for the other lung right here, right? But the 3-2 is not particularly anatomically important. It's just probably an evolutionary anomaly. Okay, so pulmonary arteries to lobar arteries. And of course, you guys know, but reinforce it. The blood in the pulmonary arteries and in the lobar arteries is high oxygen or low oxygen? Low oxygen, good. So you are going to deliver it, ultimately, those arteries are going to branch and form some more that you don't need to know the names for, to smaller arterioles and then to the capillary beds of the lungs. The capillary beds of the lungs are weird looking because this is the only place in your body in which you need to actually run blood by an air sac. Yes? Okay. So I need to run blood by little bitty microscopic air sacs called alveoli. There are so many of these alveoli in your lungs that in an average sized person, if you stretched out the surface area for gas and air exchange, you have about the size of a tennis court. That is how much area for gas exchange you have. So we're just looking at a little bitty tiny bit of it, but notice that the capillaries look weird because what I need to do is I've got this air sac right here and I need to snuggle up a capillary bed that runs right by that air sac, just like what you're seeing right here. Do you see? Okay, so what I'm doing is I'm delivering blood into the lungs. Ultimately, you followed it back. It would have come from a pulmonary artery, which would have been delivering low oxygen blood, right? And the gas content in this blood is low oxygen and what carbon dioxide? High carbon dioxide, okay? And the air that you breathe in on this planet is what oxygen and what carbon dioxide? High oxygen, low carbon dioxide. It's not 0, but it's low carbon dioxide. And what happens is when you run the blood by the air, so let's say blood's on this side, air's on this side, okay? Blood, air. Which direction is oxygen going to move? Into the bloodstream, yes, down its concentration gradient. Which direction is carbon dioxide going to move? Into the alveolus, down its concentration gradient, right? That's all you have to do. It's just get them close to one another and you get passive gas exchange down concentration gradients. That makes sense? Okay. And then what's going to happen is after you run by this, you've got nice, rich, juicy blood that now I am going to deliver back, right? I'm going to deliver it back to what chamber? To the left atrium, and I'm going to deliver it back via, by the way, let me just go ahead and tell you, even though they're not on the picture, usually what you have is 3 right lobar veins and 2 left lobar veins, right? Which will then deliver into, usually in most people, 2 left coronary arteries, 2 right coronary arteries. But every once in a while, somebody still has 3 right pulmonary arteries. Some people still have 3. Does that make sense to you? That you could still have 3, right? It's not uncommon at all to have 3 right pulmonary arteries and 2 left, but most people have 2 and 2. So these are going back into the left atrium. So good? Okay, back into the left atrium. All right, so let's make sure you guys got all of this. Okay, so we're going to go back into the left atrium. All right, so now we are going to start with systemic circulation. So here's what I want to remind you of about how I test on vessels, which is not on this test, but is on the 4th test, okay? With any vessel, I want to remind you that I am just as likely to ask you to name the vessel as I am to ask you which direction blood is flowing through the vessel and the gas content in the vessel. because I really want you to put together the big picture instead of just hammering on rote memorization, right? So with that in mind, when we talk about arteries versus veins in systemic circulation, remember that when you are in an artery, you are on your way to work. So think about what the artery supplies. Okay, so for instance, you guys will find the superior mesenteric artery. You're going to find that later. You haven't done it yet unless you've already been to lab this week. So a lot of people can name the superior mesenteric artery, but it is just as important to me that you can tell me that the superior mesenteric artery supplies the entire small intestine. Yes? So that's what it is supplying. Does that make sense? The superior mesenteric vein, again, a lot of people can find the superior mesenteric vein, but they didn't put it together with the fact that the superior mesenteric vein is actually going to drain the same thing that the superior mesenteric artery supplied. Does that make sense? So when you are thinking about this, what I want you to remind yourself is that arteries supply, so you're going towards something, yes, and veins drain, yes? Okay, so when you are following an artery, follow it to a capillary bed, from the heart to a capillary bed, right? And when you are following a vein, follow it from a capillary bed back to the heart, right? Does that make sense? So that makes you think in terms of traces, and then traces aren't as hard when you've been thinking that way the whole time, right? Okay, so you guys tell me, with systemic circulation, here's most of your systemic arteries. You don't learn all of them, of course, but you learn a decent chunk of them. And systemic arteries, all systemic arteries flow from which ventricle? Left ventricle, right? Through the aorta. Every single one of them comes from the aorta. And arteries are supplying capillary beds with oxygen and nutrients primarily. And systemic arteries are relatively high pressure. As I mentioned, at rest, 120/80 is usually their pressure because of the left ventricle. And then every single systemic artery ultimately comes from one artery. And what is that one artery? What's the one artery? It's the aorta, yeah? Okay, the aorta, right? Okay, now, with systemic veins, what you need to think about is what they are draining. Generally, by the way, veins run along with their artery friend, but then they also have two more friends, right? So you are going to have brachial arteries, yes, brachial arteries going out here. You're also going to have brachial vein or veins. There might be more than one, is that right? And then you might have some superficial friends as well. But when they run right next to an artery, they're usually called the same thing as the arteries. And there are 3 times as many veins as arteries. Many of them are superficial. Veins are far more likely to be superficial than arteries. You don't have to learn 3 times as many veins as you do arteries. I think you only learn 1, 2, 3, 4. I think you only learn 5 superficial vessels. That's sure as hell not all of them, right? But you learn 5 extra superficial veins that you didn't learn an arterial counterpart to. And of course, there's lots more variation in veins than there is arteries, both patterns, locations, and branching. So a lot of people get really, really caught up on, what do I call this if it looks slightly different? Well, if you've got a vessel that is running through this region and it's deep next to the brachial artery, I don't care if there's 1 of them or 3 of them, call them brachial veins, right? So it is, memorization is fine, but understanding is better, right? So I'll show you guys this as we run through this. So it's not as hard as you originally think it is. So what veins do is drain blood from the capillary beds of any organ. So you're going to follow it back to the heart, right? The capillary bed is, of course, invisible, right? But you know that it exists there. So if you were following, for instance, the superior mesenteric vein, you would follow it back from the capillary beds of the small intestine, for instance, back all the way to the heart. Does that make sense? Okay. So, and ultimately, all of your systemic veins are going to dump primarily into 2 vessels. The superior vena cava, if you're dumping anything from head, arms, and top of the chest, yeah? And the inferior vena cava, if you're dumping it from below there, or which vein dumps from the heart back into the heart? Coronary sinus, right? All of your veins are going to end up in one of those 3 places, yes? Okay, well, we already did coronary circulation, so. All right, so here's how we're gonna do systemic blood flow. Here's my plan, ready? So what we are going to do, instead of, these are all the arteries and these are all the veins, here's what I'm gonna do. I am going to start from the aorta, because that's where it all starts, right? Systemic circulation. I'm going to deliver blood to an organ and then deliver it back from that organ, back to the heart, right? So you think about circulation as a story instead of as a memorization, right? Okay? And then, so the first thing, you guys see if you remember, because we've already learned this part. The very first organ to get systemic arterial blood flow is what? The heart, yeah, right? So that's the first part of systemic circulation, and we know that story, right? The only two branches off of the ascending aorta are what? Right and left coronary artery. By the way, there are a couple of other little branches, but they're too small to see, and they mostly go to the atria. Okay, so the right and left coronary arteries, everybody good with that? And you know that those branch and deliver blood to the capillaries of the heart, and then you suck all that blood back up and dump it into which vessel and then which chamber? Coronary sinus, right atrium, right? Okay, so the first part of systemic circulation is the heart itself, right? But we already did that. I just want to acknowledge that you don't need to pretend that it's not part of systemic circulation, right? Because we know that. But now the next part of systemic circulation starts with this figure right here. So we know the parts of the aorta, right? We have the ascending aorta, the aortic arch, and then the descending aorta. So here's the big picture. The ascending aorta supplies the heart, right? The aortic arch supplies mostly head and arms, yes? And the descending aorta supplies everything else on its way down. Chest, right? Abdomen, legs, and junk on its way down, right? So what we are going to do is we are going to give blood off of the aorta in the order that it goes out. So we already did the heart. So the next thing we're going to do, head and arms, right? Then we're going to start heading downwards. Does that make sense to you guys? Okay, so let us get started with that. All right, so the aortic arch has three major branches. Let's look at them. Okay, so this took off the heart. So you got the ascending aorta already did its job, and now we've got the aortic arch. This is something that people got really, really confused about so often, but I want to explain the why to you instead of just the what. Okay, so do you see the aortic arch usually has three branches? 1, 2, 3. There's one cadaver that has 4. It took us forever to figure out what the hell that fourth branch was, but it was pretty interesting once we figured it out. Okay, so it's got 3 branches. So here's something that you guys need to understand. In the vast majority of the population, the aorta arches left. It goes over to the left side. Okay, that means if I am trying to give blood supply to the left side of the head and to the left arm, I can go directly off of the aortic arch. Does that make sense to you? If I am trying to give blood supply to the right side, I have to jog back over there before I give blood supply to the right side of the head and the right arm. Do you see this little jog right here? Okay, that jog is only necessary on the right side because the aorta goes left. And this little jog right here is going to give blood supply to the head and the arm, so it is called the brachiocephalic artery, or the brachiocephalic trunk, either one. Okay, do you see that? Okay, so everybody good with that? Good, you guys got it. The last class didn't know what the hell I was talking about the whole time. I'm like, you got to get back over there. So you jog over to the right side, but then after you get over to the right side, the circulation pattern is going to be exactly the same. Okay, so here's the deal. You go brachiocephalic, yeah, and the brachiocephalic is going to deliver blood to the head through a vessel we'll learn in detail in just a second, common carotid artery, and then to the arm and the shoulder through the subclavian artery. Everybody with me? Okay. But on the left side, you don't need an extra jog. You just go directly to the left common carotid artery and directly to the left subclavian artery. Is that okay? Okay. So after you get into the common carotid or the subclavian, the pattern is exactly the same, left and the right side. The only difference is that one side has one more vessel in the story. And which side is it? Right side. Yes? The right side has one more vessel in the story. Yeah? Just because you have to get back over there. Everybody good with that? You promise? Yeah? Okay, good. I must have just not explained it as well as the first class. Okay, so here we go. So what we are going to do is we are going to get into the common carotid and the subclavians. So let's just explain that in just a tiny bit more detail before we start splitting off. So what we have is the common carotids. Anytime you have a common vessel, it's going to branch in a second. It's either going to branch into an internal and an external, or a superficial and a deep, or something. It just means, hey, I'm about to branch into 2 other things, right? So the common carotid is going to branch in just a second. What it's going to do is it's going to give rise to blood supply to the outside and the inside of your head, primarily, okay? And then this subclavian is called subclavian because it goes where relative to the clavicle? Yes, that's why it's called subclavian. Yes? Okay, so the subclavian is going to mostly give blood supply to the shoulder and the entire arm all the way down to the hand. Good? Okay, so let's pick out a branch. We are going to do arterial blood supply to the head. Most of the arterial blood supply to the head is going to be through this little guy right here. Okay, so let's look at it from this perspective. Okay, so arterial blood supply to the head. Which side am I looking at? I'm looking at the right side. Get me there from the aortic arch. Aortic arch, brachiocephalic artery or trunk, yes. And then the right common carotid, right? So I'm in the right common carotid right there. And what is this one? Subclavian. So I'll pick that one up in just a second. Most of the blood supply of the head comes through the common carotid arteries. Left or right, doesn't matter, right? This one just showed you the right side so that you could do the most complicated one, right? Okay, so this is the right common carotid artery. Now, if I just tell you what the internal and the external carotid do, I don't have to tell you which one's which. You ready? The external carotid delivers blood supply to the outside of the head, the facial muscles, and the skull. The internal carotid delivers most of the blood supply to the brain. So tell me what this one is right here. That's the external carotid. Yes? Now, don't label it at a branch point because it's on the outside of the branch point, because arteries can do whatever the hell they want. So how do you make sure that you're looking where you think you're looking? You follow it. Yes, you follow it. Does that make sense? Okay, so that's the external carotid. And then this little guy right here is the internal carotid that goes through a hole that you learned. Carotid canal. Yes, it goes through the carotid canal. Does that make sense? So it goes through the carotid canal and delivers, the pair of internal carotid arteries delivers 75% of the blood supply to the brain. 75% of the blood supply to the brain. Good? So that's the internal carotid. Ready? Okay, we've got one other vessel to pick up and then we'll look at the whole story. Okay, so the internal carotid. So here's external carotid, here's internal carotid. We do have to pick up that last 25% of the blood supply to the brain. Now, follow me, because that comes from here. Ready? We go subclavian for just a second, and then we branch off to subclavian, and we send this vessel right up here. This vessel is called the vertebral artery, paired left and right. Okay? The vertebral arteries run through holes in the cervical vertebra. What are those called? Transverse foramina of the cervical vertebra. They're called vertebral arteries. They run up parallel, right? And then they dive anterior to the medulla oblongata and run up the foramen magnum to the brain. Okay, those are the paired vertebral arteries. Got it? Okay, so now let's look at all of that as one story. Ready? Okay, now the paired vertebral arteries. Ready? So here's my paired vertebral arteries, right? Running anterior to the foramen magnum. These two right here are my what carotid arteries? Internal carotid arteries, right? Collectively, these four, 1, 2, 3, 4, deliver all of the blood supply to the brain, and they're fantastic examples of collateral circulation in which if you get a blockage or a damage, you can go around another way. The only other vessel that you need to know in this story is this little guy right here, where the vertebrals come together and run up the cleavage of the pons, right? The pons has a little dip in the middle, and that's called the basilar artery, right? And so you can even see most of these as you're looking here. Here's the paired internal carotid arteries, right? This is the basilar as it runs up here, and one of the vertebrals got damaged down here, right? Is that good? Okay, so basically, most of the blood supply to the brain came off of the common carotids, yes? And then branch of the internal carotids. But a little bit of it came off of the subclavian, right? Does that make sense? Okay. And then you get it all up there together. So remember that this pattern of circulation is called the cerebral arterial circle, or the circle of Willis. Yes? Circle of Willis, this whole circle that you've got here. Okay, so here's what we're going to do. Now we are going to deliver blood back from the head back into circulation. Predict for me which big vessel it's going to go into before it dumps into the heart. Superior vena cava, that's where it's going to dump. Does that make sense? Okay, it's going to dump into the superior vena cava. So let's figure out the big picture first. So the big picture starts here. So ultimately what we are going to do is we are going to dump blood back into the superior vena cava. You may or may not have learned this yet, but let me tell you how you form the superior vena cava. The superior vena cava forms from the right brachiocephalic vein and the left brachiocephalic vein. When those two come together, you form the superior vena cava. Now, we have two brachiocephalic veins. We only have one brachiocephalic artery. Okay, so I'll show you where the brachiocephalic veins form and like put this all together for you. All right, so here's the deal. Draining your head, what you are going to do is you're going to drain the outside of your head into a vessel. You're going to drain the inside of your head into a vessel, right? You're going to dump it all into this vessel, right, which is generally the subclavian, until you have gathered up everything from your arm and everything from your head, and then it becomes brachiocephalic because it just gathered up brachio and cephalic. Yes? Does that make sense? Okay, so let's figure out if we can label these. Okay, so I'm going to tell you that these are all going into jugular veins, right? Which jugular vein do you think drains the inside of your head? Internal jugular vein. Which jugular vein do you think drains the outside of your head? External jugular vein. What would you call this little vessel that's running through those holes? That's what I would call it too. Yeah? Does that make sense? So this is gathering up and draining the vast majority. And those all dump into your subclavian. But then after you've dumped all three of those in and gathered the blood up from your subclavian, then it becomes brachiocephalic. And then with the brachiocephalic, again, what we do is we put the two brachiocephalics together, and then they become superior vena cava. And they dump into which chamber again? They dump into the right atrium. Got it? Okay? You good? Okay. So before we go any further, and we're about to do the arm in just a second, let's show you how freaking brilliant you are. You ready? This is dyed arteries, okay? This is how, for instance, they will do diagnostic angiograms, okay? So let's see what you guys can figure out. I would never test you from this, by the way. You can get done, they can do that in your clinical programs. But let's see if you can figure out where the hell you are. This is all arteries that are dyed. What am I looking at right here? Aorta. Ascending aorta, and this is aortic arch, right? What's this vessel right here? Brachiocephalic trunk or artery, right? All right, let's see if you guys can do this. What is this one? It's the right common carotid. Got it? And then as it goes in here, what is it? That's the internal carotid artery, right? What is this guy right back here? Not jugular. That's the vertebral. Yeah, that's the vertebral. That's a vertebral. Does that make sense? That's a vertebral back there, and you can sort of see them starting to form. So the vertebrals come up. That's actually the basilar, by the way, running up the anterior surface of the pons, right? So you can start to get the patterns that you feel really comfortable with this. What is this guy right back here? Yeah, that's the left subclavian, exactly, right? So do you see, once you know the pattern and can sort of, you know what comes next, and it's not as difficult to figure it out? Is that good? Everybody good? Okay. So I wouldn't test you off that, but it's good to know. All right. So go ahead. Did you have a question? No? Okay. All right. So basically what we are going to do is we are going to deliver it back into this. The only other thing that I need to tell you is that although I don't usually test you on these specifically in lecture, remember that when you are draining the brain, before you get into the internal jugular, you have to do all of these sinuses. Now, the reason I don't usually test you on them in lecture is because they're really hard to see 2D. You kind of need a 3D picture. But remember that when you are draining the blood from your brain, you also have to drain cerebrospinal fluid from your brain. But please look at where it all ends up. It all ends up in the internal jugular vein. Yes? Okay, so let's just look through this just briefly, realizing that I generally will not ask you sinuses in lecture. Okay, except for the superior sagittal sinus, because everybody can find that one, right? So this is superior sagittal sinus. The blood is going to be going back that direction, ultimately into the transverse, and then wiggle into the sigmoid, and then the sigmoid dumps into the internal jugular. But you also gather the inferior sagittal sinus, the straight sinus, all of those are going to gather, and they're all going to dump into the internal jugular vein, right? So do you see why those vessels are pretty wide? Yeah? Because they're dumping venous blood and cerebrospinal fluid. Go ahead.
So does it take the superior and the inferior and the transverse and goes to the sigmoid?
Yes, exactly. The sigmoid is the last part of the story, last part of the sinus story before you get into the internal jugular vein. Does that make sense? Okay. So I don't usually make you do flow through the sinuses, but I did want to put it back together as one whole story. It's just hard to see where you would go, and it's hard to like keep track of things. Everybody okay with that? Okay. So now what we are going to do is the obvious thing to do, which is now we are going to go subclavian, yeah? Right? Subclavian delivered a little bit of blood supply to the brain, but then mostly it does arm and shoulder, yeah? Okay, so now we are on the right side. Tell me how I got here from the aortic arch to the right subclavian vein. Yeah, aortic arch, brachiocephalic, yeah? And then subclavian, right? And it's called subclavian pretty much after the stuff to the head branches off, then it's called subclavian. But if it's under the clavicle, I'm not going to try to trick you. Call it subclavian if it's under the clavicle, right? And you don't need to try to trick anybody with this kind of stuff anyway. If you are in the armpit, now let's call it what? That's what I'd call it. Now if you're in the arm, what are you going to call it? Brachial. And then once you split, usually about this level, but it varies a little bit. Once you split, you're going to go lateral and you're going to go medial. What would you call the artery that goes down that side? Radial. And this one? Ulnar. That's what I'd call them too. And then notice by the time you get down to the bottom, the radial and the ulnar form an anastomosis. Yeah, alternate route of circulation. They form two loops. One of them is on this side. It's not superficial though, because they're deeper, because they're arteries. One of them's on this side, right? So you got two arches, right? And then those two arches give blood supply to the arteries of the fingers, which are called digital arteries. They run all the way through the hand. Digital arteries, right? So it's really logical, right? So you've got two palmar arches. The one that's on this side is called the superficial, and the one that's on that side is called the deep. But note to self, it's not actually like superficial, close to the surface, right? So you've got a superficial palmar arch that gives rise to digital arteries. You've got a deep palmar arch that gives rise to digital arteries. Good?
You have a palmar arch, it's not on the palm, it's on the dorsal side.
They're both. They consider this whole thing the palm. Yes? Okay. And by the way, it's not dorsal, like it's not these vessels, it's deeper than that. You've just got two different layers of them, and one of them is closer to this side and the other one's closer to that side. But they're both arteries, so they're pretty deep. Okay? So superficial palmar arch, digital. Deep palmar arch, digital, right? Anastomosis on those, okay? So everybody okay with that? You got a couple of other little vessels, but basically if it's running through here, call it brachial. If it's an artery on that side, call it radial, ulnar, right? You're good? Okay. These are really, really freaking hard to dissect out. So usually we ask those from the Wireman model instead of from the actual specimen. Just because if there's very little fat, it's really hard to get the connective tissue off the vessels. And it's so labor intensive to do like a hand and foot dissection. It's crazy labor intensive. Okay, so what we just did is delivered blood all the way to every portion of the arm and the forearm. And now we need to get it back. You ready? Okay, getting it back is venous drainage of the upper limb. So we can do superficial drainage or deep drainage. Let's do the easy one first, which is deep drainage. Ready? Okay. This gets a little trickier. It's not actually that bad on an actual cadaver or specimen or even a human, but on this picture, it's a little difficult to see depth, and also it's a little difficult to tell the difference between the colors. But we are going to do deep drainage first, which is the darker one, okay? Deep veins tend to be darker, so you're looking at the deep veins right here, okay? And you're going to follow the deep veins up. Look what they're all going to do. They're all going to dump into the axillary, and then the axillary is going to go under the clavicle and form the subclavian, right? And then the end of the story is that once you gather up the internal and external jugular and the vertebral, then they're going to dump into this vessel, which is what? Brachiocephalic vein, left and right. And then the paired brachiocephalic are going to form the what? Superior vena cava, okay? So let's just pick up the deep drainage first. Ready? With the deep drainage, even though they didn't label these, what do you think these veins are called? Yeah, those are called digital veins. I don't know why they thought you couldn't handle that, okay? These are called digital veins, and the digital veins are going to dump into one of these two arches. The arches are really hard to see on an actual specimen, so I don't usually make you distinguish between superficial and deep palmar arches. But notice that we are going to dump into the darker ones. So follow the darker ones up, and you will see that I end up forming on the lateral side 2 radial veins, yes? They run with the radial artery. They're usually 2 veins. 2 dark ulnar veins running with the ulnar artery, right? Go up past the elbow. Usually that's about where it goes from being 2 and 2 to being 1 and 1. But once you go past the elbow, you call them brachial. I don't care if there's 1 there or 2 there or 3 there. Still call them brachial when you're in the arm. Good? Okay. So now you are brachial. What the brachial does is it comes together wherever the hell it pleases. Like this is just a suggestion, right? So it's going to be true like 20% of the time. So you're going to call it brachial, but then by the time it gets in the armpit, you're going to call it axillary, right? And then when it goes into the clavicle, you're going to call it subclavian, yeah? After it gathers up everything from the head, you're going to call it brachiocephalic. Good? Okay, so what you don't want to do is you do not want to memorize this picture and then be thrown by the cadaver. Because if it's running deep, it's going to be the brachial vein. Okay, all right, so this is deep drainage, and it's pretty much like arterial flow, but superficial drainage is different, yeah? Superficial drainage. So you have a lot of superficial veins, and you can see them, yeah? You can see all of these veins. And if you hold your hands down for just a second, do this, you'll be able to see them really well, right? So flop your hands down for just a second and you'll be able to see the veins. All of these are venous drainage, right? And they're all superficial venous drainage. You've got a hell of a lot of superficial venous drainage on the back parts of your hands. You have some important vessels clinically in here, right? So let's look at that superficial drainage. The superficial drainage is colored lighter in this image. Everybody good? Okay, so still you're going to go from digitals, right? Then you are going to go, please look that the superficial arches tend to be on this side. And isn't that what it looks like on your hands? Look, that's a superficial arch right there on my hand. Here's another one. Yeah? Does that make sense? So you can see that, right? You have actually probably had something poked in there or sucked out of there in a minute at some point, right? So these arches tend to be more superficial than these arches, right? So you've got the superficial drainage on that side. So notice the superficial ones are on the back. But then you start following it up. There is a decent amount of variation here. So I'm going to teach you the most common, which is only really in about 40-50% of the population. So what we do as we go up is that usually there is one big vessel that runs all the way up the medial surface and dumps somewhere up here. It either dumps into the brachial or sometimes it dumps into the axillary. But regardless of where it dumps, this big vessel that runs all the way up the medial surface is called the basilic vein. Basilic vein? Everybody good? Okay. And then there's another big vessel that runs all the way up the lateral surface. Yeah? This one is called the cephalic vein. Again, it dumps wherever the hell it pleases. Can dump into brachial, can dump into axillary, wherever the hell it pleases. So that's basilic and cephalic, okay? And then there's a whole bunch of different ways that they can branch between them, but the most common way that they can branch between them is this big vessel in the middle right here, which is a really common site of blood draws, and that's called the median cubital vein, and it runs from the basilic to the cephalic, right? Basilic, cephalic, BC, or B closer to boobs, which is one of my students told me. Like the B one is closer to boobs. So basilic, cephalic, and then between them is the median cubital vein. Good. There are a couple of variations, and one of them I think you learn in lab because there's 2 different ways. I think the actual Wireman model is different than this, yeah, but the cadavers are mostly like this. Okay, so a common variation is that you have a V instead of just a slash right there, right? Yeah, so don't let that throw you. It's just another anatomical variation with that. So that's called the median cubital. Go ahead.
Why is it called cephalic and basilic?
Cephalic, I don't know why it's called basilic. I've never actually thought to ask that before. Cephalic because it runs toward the head, right? Basilic, I don't know. I'll think about that and see if I can figure that out. Never thought to ask before. Okay, so regardless of how you get there, the superficial drainage is all going to dump in or near the axillary, yes? Okay, and then after you dumped into the axillary, you're gonna just do the same pattern. So one more time. How do I get back from axillary to the heart? Subclavian, brachiocephalic, superior vena cava, back into which chamber? Right atrium. Okay, so do you see that this is one of those things that you might not have done before, but can you see that after you do it 3 or 4 times, it's not going to be very difficult? Can you see? So even if you're kind of thrown today, it's just because it might be the first time you've heard it. But after you've done it a few times and you've worked on those traces, so when you look at those traces, they look daunting at first, but if anybody has done more than one of them, you will see that it's the same damn story over and over again with minor variations, right? Because with all of systemic circulation, you start out in the left ventricle, you leave through the aortic pulmonary valve, you go into the aorta, right? Unless you're going to the heart, you're going to go further than the ascending aorta, right? You're going to branch off the aorta, you're going to go to a capillary bed, you're going to go back to the heart, to the lungs, and then back, right? So it's the same story over and over again. So after you've done it once, do it twice, and then look at the similarities between the things, and then gain some confidence and realize it's just minor variations on the same story. It's really not as difficult as it originally seems. Is everybody okay with that? Okay. Did I show you this cool picture before? These are the sinuses. This is a cadaver dissection in which they actually injected the sinuses with latex before they did the cadaver. And look how cool they are. That's the superior sagittal sinus. What's this one? Transverse sinus. Exactly. That's the confluence of sinuses. You can't see the sigmoid because the sigmoid is actually deep in there. But it's really cool. I like that. Okay. All right. So just with our last few minutes, let's just do thoracic, arterial, and venous drainage. You're not going to like this. Nobody likes this part. Okay, so it's okay. You'll be fine. You don't have to like everything, do you? All right, so now what I am going to do is I just gave all of the blood flow to the head and the arms, right? Okay, now I just need to give blood flow to the chest. Now, I don't have that many places that I still have to feed in the chest because I already fed the lungs primarily with pulmonary circulation, and I already fed the heart, right, off of the ascending aorta. So all I really have left to do is feed the skin and the muscle of the thorax, and there isn't just a whole hell of a lot of it. So don't be at all surprised that there isn't a whole lot of big vessels coming off of the descending thoracic aorta. So the descending thoracic aorta, what it primarily gives rise to is the intercostal arteries. You have anterior, posterior, and internal intercostal arteries. I don't make you distinguish between them because it's really difficult to show on an image. But basically you have some that run anterior, some that run posterior, and then some that run deep, and those are the internal ones. And those are primarily supplying blood to your intercostal muscles. Yeah, and also the skin and stuff in that location. So everybody okay with that? There's 2 more that aren't listed on here, but conceptually I want you to figure out that these probably would come off here and it would make sense. One of them is the esophageal artery. Does it make sense that you need to actually deliver blood to your esophagus and it would come off the descending thoracic aorta? So even though they don't show it in this picture, there is a branch off the descending thoracic aorta that goes to your esophagus. Yeah? There is also a branch, and this is kind of cool and counterintuitive, called, actually more than one branch, called the bronchial arteries that deliver blood to any part of your respiratory system that doesn't get gas exchange from the air. Like the bronchioles supplying the lungs and the outer portions of the lungs that don't get gas from the air, right? So yes, your lungs get mostly pulmonary circulation, but then other portions of your lungs that don't get that will actually get systemic circulation. So some bronchial arteries. Does that make sense to you? Okay. All right. So again, they're not shown in that picture at all. I don't know why they didn't show them in that picture. Okay. So we delivered blood to these locations, and now we actually need to get it back. In addition to your esophageal vein and your bronchial veins, you've got a little weird venous drainage pattern. Everybody hates this. You can see it really well on the Wireman models, and you can also see it on one cadaver on this campus that Jill just finished. All right, so let me tell you the big picture, okay? Here's the big picture, and here's why it's weird. Since the aorta runs left, the superior and inferior vena cava are on the right side. They're close to the right side, which means that if you are going to drain into the superior and inferior vena cava from the right side, you can do it directly. But if you're going to do it from the left side, you need to make a couple of jogs on your way over. Does that make sense? Okay, so ultimately what these usually do is dump into the superior vena cava. Sometimes they can dump into the inferior because you don't tell veins what to do. But usually they dump into the superior vena cava. So let's see how that works. And this is the last little part that we will do. We have to drain all of those intercostal veins, yeah? See all the intercostal veins? And what they want to do is end up here. But if you're coming from the left side, you need to make a couple little jogs on your way up there. If you're coming from the right side, you can dump into it directly. Got it? Okay, so let's look at what's going to happen. So if you're going to do the right side, you're going to dump from the intercostal veins, all of these, okay? Don't worry about the superior, inferior, and internal. Don't worry about those. Intercostal veins ultimately into this vessel right here called the azygous vein. Azygous means unpaired. There are not two of them, okay? And then this azygous vein, watch, goes up and dumps into the superior vena cava. Got it? So on the right side, you just go intercostal veins, azygous vein, superior vena cava. Got it? I'm going to do the accessory one in just a second. From the left side, you have to do a little bit more work to get back over there, okay? From the left side, again, you start with intercostals, yes? But then depending on whether you're superficial or deep, superior or inferior, you've got two different ways. Watch. The superior ones, the top intercostals dump into this guy. This is called the accessory hemiazygous vein. Sorry about the name, I didn't name it. Accessory hemiazygous, which dumps into the azygous, which dumps into the superior vena cava. So watch me. Watch the flow. Ready? From this intercostal, accessory, azygous, superior vena cava. Okay, but the bottom intercostal veins, these guys right here, these dump into the hemiazygous, which goes azygous, superior vena cava. Okay, it just this split. You have this little weird split. Every once in a while, by the way, this little bastard dumps into the inferior vena cava because you can't tell it what to do. Okay, you ready? One more time? Okay, so right side, easy side, ready? Intercostals to, what's this? Azygous to superior vena cava. The superior intercostal veins, most of them, don't worry about that one, you don't have to learn that one. These are what veins? Intercostals dump into accessory hemiazygous and then into azygous and superior vena cava. The inferior ones on the what side? Left side. The inferior ones on the left side go intercostals, yeah? What's this one? Hemiazygous dumps into azygous, superior vena cava. Got it? And those are really hard to see and really hard to dissect out, but I know that we have one cadaver that Jill worked on dissecting them all out just recently. So you can see it over on this one. It's the female with an anterior spinal cord dissection that they took out all of her thoracic cavity, and she got those dissected out on her too. So they're cool. Okay? All right, so we will stop there for today. And no, this stuff is not on your third test, on your fourth test. You got plenty of time to digest it. Oh, yes, take-home quiz. I'm going to have it up either tonight or tomorrow. And it's open book. Please collaborate, right? It's just a are you ready for your test kind of quiz. Okay?